Welcome to The Detail. I'm your host, Cathy Antunes, and you are listening to The Detail on WSLR 96.5 LPFM in Sarasota, Florida, and WBPV 100.1 LPFM in Bradenton, Florida. Well, with me today, I'm honored to have Dr. Manuel Gordillo, who is leading he is the ID doc at Sarasota Memorial, head of infectious disease, practices with a great group that I used to call on you all when I was working in the healthcare arena and sales. Somebody who is our local expert when it comes to COVID and treated the first patient with COVID-19 in Sarasota. So Dr. Gordillo, thank you so much for joining us today.
Thank you for having me, Cathy. It's a pleasure.
Yeah. We just want to take this hour to basically for you to share where we're at with COVID, where we've been, where we're going, even though I know you don't have a crystal ball, but let's just kick it off with, it's really been 100 years since there's been a global pandemic of the scale. I would say the Spanish flu, right, was probably the last time we had such a huge pandemic. So this is not something that anybody, alive has really dealt with, or that's how it feels anyway. And there's a great, we love certainty in this country. We want the answers right away. And we want to be told how things are going to be fixed. And it didn't go that way. I think one of the things that people have hopefully learned is that there's an art to medicine and science, and that this is an evolving situation. You all are learning. Can you talk about that and how the understanding about COVID and treating it has evolved, what that's been like for you? Because you've never encountered anything like this in your career before, I expect.
Well, in a way, yes. But, when I was in training, actually, an interesting virus came along that we still have around, and you are probably very familiar with. But we don't, for some reason, we don't consider that as a big pandemic, but it's actually the largest pandemic, the HIV pandemic.
Oh.
So when I came along, I was in training, so it was the early days of HIV. So actually, all of us have been through this. It's in the evolution of knowledge on a certain virus. When I started, we knew nothing about HIV, but this is evolved over 30 years. So this is a different kind of a pandemic. It's not a respiratory virus pandemic that explodes and disseminates and affects everybody. It was a different kind, but we've learned lessons over 30 years that some of them are applicable to this current pandemic, because this is kind of like a compressed type of HIV pandemic. What we learned over 30 years, we're having to learn here over a year and a half, 2 years. Right. So yes, when this came along last year, which is something that most people in my field had been expecting. If you go back to the medical writings and the medical literature, we've been talking since the 1980s that there's going to be a big pandemic similar to the 1918 pandemic, and we have to be prepared.
So this isn't like a creation of Bill Gates. You guys were actually talking about this before he was?
Yeah, Bill, I'm sure that was talking about it, but Bill it's a very he has a wide variety of interests. So he's been reading the same stuff that I've been reading, and
he actually funds a lot of prevention.
Been talking about this thing for years, and then all the misinformants speak on this, and are saying, why is Bill Gates into this? Because he's a computer guy. Why is he talking now about epidemiology? But Melinda and Bill and Melinda Gates Foundation, they have given a lot of money for AIDS research and biomedical research, not just this decade, but decades before, since he was a young man. So back to this same, that the recent history of this virus, when we heard about this back in December of 2019, all of us, we started paying attention, because whenever you hear that there's an outbreak of respiratory virus that is contagious, all of us, our radars are up immediately. Ooh, let's see what's going on. So back in those days, there was not a lot of information. You had to usually read the newspapers from Hong Kong, which is, the closest to China, to get more information, and some other researchers that have contacts in there in China through Twitter and other modes of information like that. So, with this was struck us as very unusual from the very beginning. And at the end of near the end of the year, things getting worse and worse, until finally the Chinese actually announced that this is a coronavirus. And
what was it about the whole description that you were hearing about the clinical presentation? Was it just how contagious it was? What was it about? Yeah.
It was very contagious, and the Chinese were not talking about it, at least not the Chinese government or the local government, but there were epidemiologists in Hong Kong, which are more Western and have a lot of contacts with the West, talking about this and explaining, from local sources in Wuhan, that this was much bigger than what we were led to believe. So we were actually concerned, and as it evolved in the month of January, very quickly things kept getting bigger and bigger, and there were gaps of information where there was no growth, and we knew that something was happening. And what happened is the central government in China took over from the Wuhan, the local provincial government, and that's when there was a gap of information. But there were still scientists that were providing information through other sources. And in fact, I think it was on January 10th that one of the scientists, that not from Wuhan but from Shanghai, published the genomic
sequencing
script of the virus, the DNA of the virus, who gives it to another researcher that he had, a friend of him, Dr. Lee, in Australia. So that's how the rest of the world found out, oh yes, this is a coronavirus. And that day, a lot of places throughout the world went to work, to develop a test, number one, and then to develop a vaccine. In fact, the people that eventually developed the Moderna vaccine on January 11th started working on the vaccine the day after the Chinese and the Australians published the version of
day two
sequence. Yeah, so just even the same day. And I think it was a Saturday. And it's interesting because the director of the NIH vaccine laboratory and Dr. Kismekia Corbett, who actually was the main developer of the Moderna vaccine, it was now at Harvard, she told the story and said, the next day was a Saturday, and we thought it was so important that we needed to go back to work on a Saturday. So, it's about how government employees are lazy, they don't like to work. But, these guys, they went to work on a Saturday and they started working, even though they didn't have any idea how bad this was going to get. They figured that it was so important they needed to start working on a vaccine the next day.
So they knew. It's funny because when I was working for Merck, there was a story about how the guy who came up with Primaxin, like locked himself in the lab until he figured out, which is a very powerful antibiotic. And then there's the man who really spearheaded vaccines in the United States. There's a great podcast about this gentleman. And it is like it's an inspired effort, then people, it's like something grabs hold of them. So yeah, at NIH, they are government employees, and yet they knew right away that they had to jump all over this quickly. That's very interesting. And this particular, the coronavirus family is related to the common cold. I know there have been companies working for a cure for the common cold for many years, and haven't been able to do that. So it really was quite remarkable how quickly they came up with a vaccine, and then the storage requirements for this are unusual too. Is there anything interesting about that research, or did you expect that it would come this quickly? I mean,
No, that I don't think anybody did, and not even the developers of the vaccine, because normally a vaccine to get go from the first step, from the initial steps to having a vaccine, on average previously took 7 years. And now
yeah.
the reason it took 7 years is because we were working on very outdated, really technology from the 1950s, and also methods to develop the vaccine that nobody would like to have now, because it would take forever going from one step to the next, because usually there's lack of funding. You need to get more money. You have to go beg for money, apply for grants, and then once you get to the vaccine, you have to find a partner like Merck or some big
Right.
pharma to help you distribute. All that was compressed.
Yeah, there was a
because
big
yeah,
effort.
the government realized that we need to change this system. This is not going to work. We cannot have a vaccine in 7 years. We need to get it as soon as possible.
Get it
Even
now.
then, all of us were thinking about maybe a year and a half, not the 9 months that it took, because everything worked correctly and everything was well orchestrated, in a way that, by November, we already had a very, very
Yeah.
better than expected vaccine. So no,
You-
I don't think
you-
anybody expected that to be that good.
No.
And this is one of the greatest triumphs in COVID. We're going to look back and look at all the bad stuff that happened, but there were some triumphs that in things that done very well, and probably at the top of the list is the vaccine development.
Yeah, so actually cooperation made things just move along so quickly. Um, Dr. Gordillo, because this is a mRNA, messenger RNA, the major vaccines from Moderna and Pfizer use this technology. And what would you say, or what have you told people who say, well, I'm concerned about my DNA. Is this going to affect my ability to have children? Because it's different. It's not like former vaccines where you're taking a bit of a dead virus or slightly live, or, it's different. So what do you say to patients who are straight up with you and say, I don't know if I want to take this? And maybe they're not telling you that anymore, but when they did, how do you explain this to folks that have concerns that it really is
Well, it's a
good option? Great option.
no, and there's no, you can't criticize, because up until November, I myself was like thinking, why is it that very few people know how these vaccines are being developed, how they work? And that, I even asked my own colleagues in medicine, in all sorts of specialties, what do you know about the vaccine? They had no idea how the vaccine worked, what an mRNA vaccine was. So we probably did a poor job on updating people on the status of the vaccine and preparing them on explaining the public what an mRNA vaccine was. So by November, when the vaccine was developed, then is when we started going out and telling even other physicians what an mRNA vaccine was. So I don't think we can expect the public to all of a sudden become well-versed on mRNA technologies and what they are and what they're not.
Yeah.
So this was ripe for people, well-organized anti-vaccine groups, to immediately develop the attack that they unleashed on these wonderful vaccines. So now you have a great vaccine, and the public is being misinformed about these great vaccines, and we, the ones that needed to go out to explain, were some of us didn't feel comfortable in going and explaining because we didn't have all the knowledge. We didn't have all the data. So it was a very challenging time, and this still is, because yes, we got a number of people vaccinated at the beginning. The first 3-4 months, the country was highly vaccinated compared to other countries in the world. I think, at the beginning, we were number 3 or number 4 in the world in terms of
Really?
vaccination. But over time, we've fallen to, I think today we're the 48th country in terms of vaccination. So this is for, us, we are the richest country in the world with the highest number of resources. We're doing worse than third world countries in terms of vaccination rate. So this is some of the paradoxes that we're seeing, and some of the things that to us, it's a terrible thing to watch every day.
Sarasota County is at 62% last I looked, in in terms of vaccination. Where would you want that number to be? I mean, obviously, 100 in a perfect world, I guess, but you're going to have some people who don't. But what is the goal for this herd immunity through vaccination standard?
Yeah, well, the concept of herd immunity is a moving target. We really don't know nowadays where is it, where are we going to get this so-called herd immunity. And also the concept of herd immunity is a little bit, it's people think that it's just an unmovable number that it's out there that applies to everyone. The problem with herd immunity is that would be if the population is homogeneous. When it's not, there are pockets of unvaccinated people for measles even today in the country. So if measles comes to Sarasota, most people will be immune, but in Sarasota there are pockets of populations that are unimmunized against that, and those populations will get measles.
Yeah.
So that is for a virus where there's supposedly already herd immunity, but the reality is that the herd immunity is not homogeneous. There are going to be pockets of areas where there will be susceptible to the virus, and the virus will attack them. And the same thing will happen to this virus, even if we get, let's say that we're 90%, which is something that most people will accept as level of herd immunity. Even then, there will be pockets of unvaccinated. So the virus will still have like small tornadoes here and there. There would not be big hurricanes where people will get massively infected like we had in this recent surge and Delta. Yeah. I don't think we're going to see that, but we're going to see small outbreaks, and we will probably continue this to see for the foreseeable future. I think we need to get up to the upper 80s, 90% of vaccination. I think Portugal is the country with the highest vaccination rate in the world now. They're 88%. Iceland, Malta, they're about 87%. So I think I don't know if the US ever is going to get to that level. Those are smaller, more homogeneous countries with populations that are more accepting of the vaccine and with less historic opposition to vaccines. But I think we're probably going to have to start studying those countries and see what happens. Are they getting to some level of population immunity, which is something that I prefer to use a better term. I think population immunity.
Okay, yeah.
Than herd immunity. But I think we're still far from that. Not just in the absolute population, but also the distribution of the vaccination is very heterogeneous here. Even in our county here, the probably the richer, the whiter zip codes have much higher vaccination rate than the people of color at poorer zip codes. They have a much lower vaccination rate.
Yeah. Well, I'm curious is, to the outreach and education for those folks. And I also want to ask you about, because, we all felt pretty happy and excited that, I'd say in June, I think maybe you had 4 patients with COVID in the hospital. 3. Yeah. And, I'd heard rumblings about the Delta variant, but it didn't feel imminent. I mean, we were all kind of going back to our normal lives. Can you just share when you knew that this was an issue, and seeing this progression? How should we all, we want to live our lives. What's the best approach, knowing that there are other variants out there, right? That this is a work in progress, right? You all are learning as we go, and the situation changes. So, tell us about your experience of what happened with Delta in Sarasota County, and then how you would like to see us all be with COVID moving forward.
Yes. So, I mean, this virus, being a novel virus, is going to behave in ways that are unknown to most of us. Even the people that have dealt with viruses for many years, have been in this infectious diseases for almost 40 years, 35 years. So I've seen many viruses and how they evolve. And like, for example, influenza is very unpredictable. So when we started studying coronaviruses, we thought, well, coronaviruses doesn't mutate as much as, let's say, influenza. Coronavirus definitely doesn't mutate as much as HIV, for which we've had it for 30 years. We have not been able to develop a vaccine for HIV, even though we have all these same technologies. Because it's a much more difficult virus to develop a vaccine for mutations in a number of other reasons. I'm not going to get into that.
So it mutates a lot.
Oh, yes, there's a lot more mutations on those. And even influenza reassorts and mutates. At the beginning of the influenza season, you have one virus. Sometimes it changes. At the end of the influenza season, that the vaccine doesn't work. So yes, we're used to deal with those, but the way we saw this virus is that it mutated at a lower rate because it has an enzyme that corrects all the defects that it produces when it replicates, when it reproduces. So we thought that this is not going to be a major problem, but no, we started seeing that no, it wasn't like that. At the end of last year, we started seeing all those other variants. The first one in the UK, there was another in South Africa, another one in Brazil. That started giving us a wake-up call, and we started looking at the genomes of those, and they have several mutations in parts of the viruses that can make it problematic in terms of vaccine or in terms of increased transmissibility. And you remember the previous one to Delta was Alpha, which we saw appeared in the UK and quickly replaced all the previous ancestral strains. So we started saying, well, if this virus has some tricks that we did not expect. So at about the beginning of the year, in India, we started seeing these cases that caused a massive outbreak in India with a lot of death, probably more deaths, many more millions of deaths that had been reported from or infections or hundreds or thousands of deaths from being reported. So when we saw that, we immediately started thinking, well, this could be a problem because we were under the allure of our vaccine and how we were seeing through many countries, Israel, the UK, here, we're vaccinating and the numbers are going down. So we got to very, very low numbers. At about the same time, we saw that Delta moved from India to the UK. And that was to me, it was the biggest message this virus is not going to stop in the UK and it's going to spread throughout the world. There is no way that we can contain this.
Yeah.
Unfortunately, we were all and we was almost like we never learned our lesson, including myself, because that was a time where we started saying, well, the numbers are down, we don't need to wear a mask. The studies were coming out that suggested that we were protected even from infections, that the vaccine can protect us from that. So even myself, I'm just going to go out, not wear a mask, I'll go
Yeah, you get
indoors,
tired.
not wearing a mask,
Yeah.
especially if I had small groups and people that I knew that were vaccinated. We were happy and we were ready to celebrate until about the 4th of July when but by that time we started seeing cases in the United States, and I had friends in Missouri. I'm not sure why it started. Cases started rising there, and they got hit very hard in southern Missouri, not in St. Louis, and the hospitals started filling up immediately, and so that was a big problem. And so that's when we thought this is going to be here. And lo and behold, I think right after Independence Day, that's when we started seeing the rise in the cases in Sarasota. And once it hits, because of exponential growth, the numbers start going up very fast. We didn't know how big the surge was going to be. The virus tends to be different because there's this virus has certain characteristics where they call it over dispersion. So a few patients are very contagious, so to speak, and disseminate a lot of virus. So just about 10% of the population cause 80% of the cases. So at the beginning so we thought, well, maybe. Yeah, exactly. It could be that we get lucky and it's not as bad as in other places, but we were completely wrong. This was the worst of all the surges here locally.
Yeah, today, just looking at the statistics from Sarasota Memorial, the website, and I know, your patient numbers, I think there was a high of nearly 300 at one point, patients with COVID.
Right.
Today, the numbers are at patients who have, patients in the hospital. I've got to see where I'm at. In the ICU, it's 53, 51 yesterday. A total COVID patients today are 97, and 111 yesterday. But you lost 6 patients.
Yesterday.
6 patients died. I mean, these numbers are, it seems the proportion, this is still mainly unvaccinated people who are coming in to the hospital with COVID. But some of them are vaccinated. I would expect maybe they're immunocompromised. They have other things. The number of patient deaths now, it was 472 yesterday. Today it's 478. But Dr. Gordillo, this just, granted, SMH is the largest hospital in Sarasota County, but it's not the only hospital. I mean, these numbers are not complete. And for whatever reason, the other hospitals don't report the way Sarasota Memorial Hospital does. So it's still quite serious,
Oh yeah, absolutely. I also worked at Doctor's Hospital, and on a week, I don't go there very often, but I go there sometimes on long weekends.
And that's where.
And I was there one weekend, and in the ICU, I think they have 16 patients. I think that out of the 16, 15 were COVID. And on that weekend, just that weekend, 5 of the 15 died. And on a 3-day period. So it basically wiped out 30% of their patients. They get filled up again with more COVID patients on another floor. But yeah, proportionally, this is not just Sarasota Memorial. I'm sure that same thing happened in Lakewood Ranch and Venice Hospital. I don't go there.
Englewood, so is Englewood seeing any COVID? Do they treat COVID patients?
Where?
Englewood Hospital?
I'm pretty sure everybody does.
Everybody
you know,
does.
Yes.
Okay.
If they get to a certain level of complexity, they might send them to another place. But I don't see much transfer of patients from hospital to hospital because everybody was so overwhelmed. Nobody had
Room to take
transfer
them.
service anymore.
You know, to me, so looking at these numbers, so this is just the population from Sarasota Memorial. The patients who come in, some of them come into the ER, they're diagnosed with COVID and they're not kept. They're sent home. Most of them, you know, I'm looking at numbers, patients hospitalized with COVID. The number at Sarasota Memorial since the outbreak began is 4,589. And then when you look at the number of deaths, it's 478. That's 1% of patients, roughly, right, who are hospitalized. And you know, that I think I'd like you to put that number in perspective for people listening, because to me, that's actually really high. I mean, for a virus, this is pretty, you know, the death rate of 1% if you're in the hospital is serious. And if you get to the ICU, it's not, you know, it's bad, right? It's
Yeah, if you get to the ICU, is that those are the sickest of the sick. So if you get it to the ICU and you don't make it out of the ICU within a week, that mortality is extremely high. It's over 50% of them will die. One of my ICU partners looked at the data, and I think that it was more like during this last go around, it's more in the 60 to 70% range if you don't make it out of the ICU quickly. So some patients get transferred to the ICU because they're borderline, you know, they may need intubation and put on the ventilators. So some of them turn around. So those are the ones that might survive. But if you stay there on the ventilator for over a week, that's very severe, high mortality. And then unfortunately, of the ones that we have, some of them are extremely sick. You know, those 50-something cases that we still have, unfortunately, many of them are not going to make it out.
Yes, it's a very, very sad situation. If you're just joining us, you're listening to The Detail on WSLR 96.5 LPFM in Sarasota, Florida, and WBPV 100.1 LPFM in Bradenton, Florida. And my guest is Dr. Manuel Gordillo. He is the head of infectious disease at Sarasota Memorial, and we are talking about the current situation with COVID-19 in our community. But as a reminder, if drinking is no longer fun for you and separates you from other people, you can attend an AA meeting. They've been there. More information is available by phone at 941-951-6810 or online at aasrq.org. So, you know, just getting back to this idea of, you know, there was a perception early on, and some people still say, well, you know, I eat well, I exercise, I've got a great immune system, and so I'm not concerned. And, you know, I think though the stories, we're starting to realize most people know somebody who's been affected. I mean, I ran into a friend I hadn't heard from in a while, and I saw him and said, well, how have you been? You know, I've been thinking about you. And he said, I was in the ICU with COVID and they didn't think I was going to make it. And I said to him, were you vaccinated? And he said, no, you know, and I kind of went to kick him. I was like, what are you doing? And he goes, I know. I kind of let this hype get in the way of, you know, what my doctor would tell me to do. So just pulling back a bit, because the resistance to masks has been noteworthy. And yet, and there's also this kind of I've encountered black and white thinking when it comes to masks. Like if they're not blocking everything, they're worthless. When, you know, a lot of times it's a mitigation tool, right? And you're basically wanting to kind of stop this respiratory plume that would normally just go everywhere, to kind of contain it so that when you're 6 feet away from someone, that's my understanding of it, you know? So I'd like you to talk about, you know, we've seen kind of a swagger out there about, well, you know, you get to choose and I don't really need, you know, you get to choose if you want to wear a mask. And boy, the school board meetings have been, I've seen a lot of meetings, Dr. Gordillo. I've never seen meetings like the school board. It's been pretty crazy. So on the one hand, you've got this, you know, I'm really tough and I'm not going to use a mask, or I want that freedom of choice. And then there's this other, hey, we've got this monoclonal antibody, and you know, we're going to recommend that. To me, working as I did in pharmaceutical sales, you're in, by refusing the simplest and actually really effective prevention tool, you're expanding the population of infected patients for using the monoclonal antibody. It's a great thing that we have it, but gosh, if you contain the number of people who need it, you're so much better off. Can you just speak to the attitudes you've seen, and, you know, are the United States an acceptance of masks, and what your observations are, and any, I don't know, any tips or things for people to think about when they're making their decisions?
Yeah, I mean, it's a study in sociology. I think this is going to be a very fertile area of research for the future, and sociologists will probably have to investigate more why in the United States there is such a low acceptance rate of masks, when just about in every other place of the world there people don't make this big issue about masks. And it may be just be, you know, the tradition in the United States where, you know, the ragged freedom, this is what we want. And, you know, we conquer the West, and back to the time of the American Revolution, and we still have that spirit, and nobody can tell us what to do.
Mm-hmm.
And it's all about me, and don't tell me, well, I don't care about what happens to the rest, you know, it's just me and me.
Rugged
Maybe that
individualism.
has helped us out, and maybe that has what helped
Mhm.
this country be what it is, you know.
Right,
But
there's an
unfortunately,
upside downside to a lot of most
that
things, right?
particularly doesn't work very well in pandemics. Unfortunately, maybe works very well to make money or
Mhm.
to develop businesses, but doesn't work for public health and to fight pandemics, you know. And it leads to all this tribalism where, you know, it's, you know, one party against another one, you know, groups against another one. And this is a constant fight. And I think the social media, having access, everyone has access to social media. And there's some certain anonymity to that, you know, and people get really angry, and there's all these exchanges that foster all this, you know, and then it leads to certain scenarios like you described the school board. I think the school board is it's like a microcosm of part of the society where, you know, we allow very vocal groups that are very, you know, very extremist, and we, because of our freedom of speech, we allow them to express themselves in any way they want. But I don't think that that represents the majority of the population.
Yeah.
Um, Not even the ones that don't like the masks, you know, I don't think they will go to those extremes. You know, this is just the 5% of the population that espouses these radical extreme views.
Mm.
But I think the mask is interesting because I did not know, for example, if you go to the 1918
Spanish flu?
it's not
Or-
Spanish flu, in the US, we used a lot of masks. And, there's not a whole lot of history, but in many places in the United States, people would wear a mask, and this is a time where masks weren't even in the news. It was just something that people learned to use. And they found that's where their technological advance. So everybody felt like that was the way to go. And in fact, I heard that from the US, it disseminated to Asia. But in
Well, it
the
started
US, it was
here.
abandoned. And in Asia, it was taken as a good measure to fight pollution and to fight viruses. So it became a tradition in Asia for years. They've been every time there's a virus season or just to fight pollution, people over there wear masks. We gave up on that and we don't use it, and
So it
doesn't
might
work
have
here.
been no stigma. If anything, it was like being healthy, you would put on a mask. And there was maybe even, a totally different attitude about
Yeah.
it in Asia. Hmm.
Yeah, so here it become an industrial thing, for certain industries, you're mandated to wear a mask,
Mhm.
so in our healthcare industry, our surgeons and people working in the operating room have to wear a mask, because they have to protect the person they're
Open.
operating.
Yeah.
So they don't get contaminated and they don't get infections. So our surgeons and surgical specialists understand this concept very well. But
Yeah.
that didn't translate to the population. And when it was necessary for the population to take up mask, all these fringe ideas came along that the mask will make you sick, that the mask will contaminate you, that the mask will cause hypoxia, all the things that are just folk. There's nothing, no science to it. Historically, people in working in industries where there's pollution actually get a lot of protection from masks, and that's the reason they wear a mask, so they don't get sick.
Yeah.
And our surgeons and our nurses that work in the operating room, they've been wearing this for years, never had any damage or
Mhm.
infections or sinusitis or any of the things that these people claim. So I think there is that side, misinformation, misunderstanding, and then
Mhm.
there's the sociological part against mask. Don't tell me what to do.
Mhm.
That sort of attitude that it's kind of unique to us in the United States and not in other places. But obviously, there's people saying, well, proof that the mask works, and it's very difficult to prove that mask works. People have been actually trying to do that, because doing the studies of a mask in the population is difficult. Who's going to be doing the study? How do you do it? Who's going to be checking whether people are wearing the mask at the time that they say they're wearing? So it's been
Mhm.
difficult. And in fact, most of the studies are done in Australia and in Asia.
Mhm.
And the studies were done for other viruses, so we have very few studies for our viruses. So most of the data is observational. Most of the data is from laboratories, or more of the data is what we see every day. For example, in the hospitals, we all wear a mask. We don't get infections in our hospital because we're wearing masks.
Yeah.
There's nice studies, for
But, you know,
example, in the carrier that there was
Mhm.
an outbreak. The people who are wearing a mask, they have like 80% less infection than
Are
the
you
people
talking
who are
about
not wearing masks.
a industrial setting, carrier air conditioning, and they were wearing, okay, because, just coming from, industry where, pharma, we'd be showing these, well, placebo-controlled trials, and, the idea of, okay, how are you gonna ask a patient population where there's so much observational evidence, like you're describing, that masks are protective, to go without the protection and expose themselves to COVID? I mean, that's kind of the gold standard for a study, but it's totally unethical, right? Because there's gonna be people, I mean, they stop studies when they know that there's gonna be this, or they won't even approve them starting. So, you had mentioned, though, that in the US, we really like the more technological solution. We like a drug, we want a pill, we not want a procedure, and it's very curious to me that the monoclonal antibody, which has a wonderful place, and it's the great thing that we have it. But it shouldn't be plan A, right? I mean, isn't the
Right.
mask the appropriate plan A instead of,
Yeah.
you know,
So
uh,
absolutely, like I think we were talking before we started, we did the study, the original randomized control placebo controlled trial here in Sarasota, and Sarasota Memorial was one of the leading hospitals in recruiting patients for the study. So we're very familiar with the
for the
data.
Regeneron
And we
monoclonal
published
antibody.
with the Regeneron the results of the original study in the New England Journal of Medicine back in January, and this led to approval authorization by the FDA in March or April. And we started using this monoclonal antibody here. We opened our clinic here locally, offering this before anybody, and we couldn't convince people to use it because,
Really?
yeah, we had
Oh,
it all open, and we advertised it on social media and various places. We even called the doctors and say, hey, if you have patients with this, you please send them over. But nobody would follow. Very few. We had sometimes nurses there waiting for patients, and nobody would show up.
so there was a resistance
Yeah, it was
early on.
there was a resistance, and
Wow.
not only among the public, but also among physicians and referring patients to this,
Mhm.
because it wasn't advertised
Yeah, there was some.
by the public, and even though it was free, the drug was free, the previous administration, when we were doing the study, actually they saw the potential value for that and gave Regeneron $500 million to develop the drug, and told them that even if the drug doesn't work, we're going to buy your production. So go ahead and start producing. So they opened a factory in Europe, I believe in Ireland, to start making this stuff. So because it's hard to produce. So
Is it?
they produce a large number of vials. So we had this material to give it, but there were not a whole lot of use. Now the drug is, the way it's been marketed now is incorrect. The FDA approved it for up to 10 days from the onset of symptoms. But
Okay.
what we saw in the study is that it really works well in the first 5 days, and the earlier the better. In fact, Donald Trump, when he got it, he received it like on the second or third day of his illness, which is the
Wow.
best time to do it.
Really? So you should,
Yes.
if you have symptoms that could be COVID, so this is an important takeaway. If you have symptoms that could be COVID, you should get tested right away, and then you gotta get in there for that monoclonal antibody. Quick.
Yes, exactly. What we were seeing even now during this outbreak is that people, first of all, they were not getting tested as soon as they had symptoms. They waited 2-3 days. Then after they waited 2 or 3 days, they didn't feel that bad. So they were waiting another 3 or 4 days. So by the time they got to get the Regeneron drug, they were about 7, 8, 9, 10 days into the illness. At that time, it doesn't work.
Really, really.
So
So
there's a lot
you've
of
gotta
wasted
take it.
drug, so the time to do it is early in the disease, but,
Okay.
the public, first of all, didn't have the understanding. There was not enough emphasis in educating the
Okay.
physicians and the patients that if you are going to receive this, you need to do it right away.
Okay.
And then it got to a point where now a lot of people knew about this. So now everybody wanted to get into that, but we had limited resources. So that we could only do a certain number of this a day. So even though you wanted to go the next day, you couldn't do it for 3 or 4 days. Fortunately, the governor opened clinics here that led to more use of this. The problem became the opposite. Now everybody, even if they had 10 days of illnesses, would go and get it when it was not going to work.
Less
It was too
efficacious.
late, but they would still give it because it was available. And kind of in a way it's a waste of resources, but it didn't matter because if you don't give it, it's going to be wasted anyways. Kind of the same story as the vaccines. We have vaccines here. We've been wasting millions of vaccines in a month in the United States because they expire. This is kind of the sad part.
That's how I got my vaccine. That Sarasota Square Mall, they were having a clinic, and they were going to be expiring, and a friend of mine was down there working, and she said, "Do you want to get it?" And I was signed up, but she said, "It's going to expire. Come down now if you want, and call anyone you know who wants to get it." So I came and got it, and they would have done that for anyone. They didn't want the product wasted.
Right.
So there's a couple things I want to ask you so that people can understand. If you're displaying, first of all, describe what kind of symptoms would prompt someone to go, and we've got like 10 minutes left. When should people do a COVID test, and how should they do it? And is it adequate can you purchase one that's effective? And then based on that result, will you get the monoclonal antibody? What's really the best protocol, and how do you decide, gee, I better get tested right away?
Yes, well, that's one of the failures in the United States is the testing part. In many other countries, you go to any corner on any neighborhood and you get a test. Not in the United States. We still have to go to, a couple of places that the state or the county have, and you have to stand in line. So it's not easily accessible, or you have to buy a kit, which if you find it, many times you go to the drugstores and they're out of it.
Okay.
So if you're lucky, you will find it, and it's still, there's a certain cost. If you go to the dog track, it's free, but you have to have a car, you have to have the time, go all the way there. Sometimes you have to stand in line. So there's a lot of barriers to get tested. Alternative, you can go to a pharmacy and pay the cost for that. Also, it is a barrier, or you can buy the test kit and do it yourself. The problem is that the test kit, it's a good test, but there's about 7 steps. So if this is the first time you're doing it, you have to read carefully, you have to understand the instructions, and you have to do it just as it says there, because if you mess up even one step, it give you the wrong result.
Okay.
So you have to do it right, and it costs about $25 for 2 tests. So I think if you can afford it and you can have a bunch at home, that would be advisable, because you have to, with this disease, you have to do it as soon as you start having any respiratory symptoms. That for sure. If you start having congestion, headaches, body ache, fever, for sure, you need to do the test.
Okay.
And if you are positive and you have risk factors, and again, the monoclonal antibody is not for everybody. It's people with risk factors, all those 65 and over, or older than 12, but with risk factors: obesity, hypertension, respiratory illnesses, neurologic illness, metabolic illnesses, diabetes, you name it.
Yeah.
There's a whole list. But if you're totally healthy, you're not going to qualify for this.
Okay.
But at least you need to know, because then you need to be careful in not transmitting this, and you need to quarantine. So that's why it is important to do better testing, have more accessibility of testing. The tests that are sold are good, but you have to do it as it is in the instructions. Otherwise, you're better off going to get tested anywhere you can get the test.
Okay. So, I know you made a recommendation about masks in school, and the school board has decided, because the positivity rate, the testing rate for COVID, the positivity rate in the community has fallen below 8%, I believe it is. And so they're making masks as a policy optional. When parents ask you what they should do with their kids in school, how do you advise them?
Yeah, it's a difficult question to answer, because I do believe that when there is a low transmission rate in the community, there is something to be said for no masks at school. But what is the threshold? I think that's where people will disagree. I think 8% is a high threshold.
Mhm.
Most communities in the country use the 5% threshold.
Okay.
It's a good threshold because in general, when you hit that, you're in a downward trend. You know,
Okay.
and the viral kinetics, the dynamics of the viruses is they tend to move in one direction.
Oh,
Okay,
really?
so when the numbers are going down,
They
well,
tend to
there is a
slide down.
strong tendency to go down. You know,
Okay.
in order to turn them around, something big has to happen to turn
Like a
them around
variant, right?
and start going up. Yes,
Yeah.
a variant or some
Mhm.
big event. Something big has to happen. So when you see the numbers coming down, hit 5%, they're probably going to continue to go down. I don't know how low they will go, but they will
Mhm.
continue to go down. On the other hand, if you're seeing the numbers going up, it's likely they will continue to go up to an unknown height. So
Which is that
the
exponential
5% is
growth,
one
right?
number. There's another number that people use, which is the number of cases per 100,000, which is
Okay.
a little more stringent. Some people use that as 10 cases per day per 100,000 in the population. So that's even a better number. If you go below that, it's probably very little transmission in your community, and the kids can probably go with no mask.
Mhm.
If there are other things other things that are done, because people frequently quote, "Oh, what did they do in Denmark? The kids go with no mask, or in certain parts of Germany." But what they don't consider is that there are other things that they do in Germany and Denmark. It's a different population. The schools are more open. They have better ventilation. The
Oh,
kids do a
really?
lot of more outdoors activities.
They have recess.
So yeah, they have a lot of testing too. You know, they
Yeah.
test the kids frequently. They have very good contact tracing. Their health departments are well funded. They have a lot of contact tracers. Even they
Mm.
have nurses in schools, which we basically don't have here. So we're very just we tend to go to only one thing here, or it's a mask or nothing, it's a vaccine or nothing, as
Yeah.
opposed to using every possible tool that we have at our disposal. Now that is it's because of because we were talking at the beginning, public health infrastructure in the United States have been deteriorating over years, and the same
Mhm.
thing goes for applications of these public health issues to schools. You know, we have schools here with very poor ventilation. There is no way that we can solve that problem in a short period of time. Many schools don't have a school nurse or school nurses that don't have enough resources to run programs, and it's very, very difficult to run a school these days. And I sometimes feel for the superintendents and all the people on the board and all the teachers. It's difficult for them.
So, you know, just to wrap up, because we're coming to the end of the time here, the numbers that I'm looking at, and this is from the New York Times, is specific to Sarasota County. They're saying there's an average of 144 cases per day, which is a 53% decrease from 2 weeks ago. So, you know, the numbers are going down. Since the beginning of the pandemic, at least 1 in 8 residents have been infected. So right now, they're saying Sarasota County is at an extremely high risk for unvaccinated people. Does that jive with what you know about, you know, the numbers you're seeing? And it does sound to me like if you're on the fence about vaccination and you haven't done it, it's, you know, it's time to really consider if that's what you want to do, right?
Yeah, so that number is just a raw number. If you
Mhm.
consider there's about 420,000 people in Sarasota County, it gives you a rate of about 35 cases per 100,000 population. So we're still, but the number is going down.
Yeah.
So as the safe number is considered 10. So hopefully we'll be there in probably 3 weeks
Mhm,
if we continue to go down at this rate. We're
mhm.
not there yet. So it's still very problematic. And most of the cases are occurring in the school age children or in young adults in their 20s. That's where most of the cases tend to occur.
Mm,
So that is a problem, because we still, especially in poor kids that live in multi-generational homes, that's what we're seeing. We're seeing some of the people that come to our hospital here very ill are grandfathers of children that went through a chain. The children gave it to the parents, and the parents to the grandparents, or they gave it to somebody that has cancer or some other immunocompromised 40-year-old, or to some pregnant person there, and then we end up with those
yeah,
folks
so
here
it's
in the
really,
hospital.
the kids do tend to survive much better, but they are, they're part of our community and they bring it home. Um, well, Dr. Gordillo, thank you so much for the work that you're doing. And I hope that the healthcare workers, doctors, nurses who are doing so much, I know it's been exhausting, and I'm hoping it's getting better for you all. And I'm sure I speak for many in the community about the deep gratitude that we have, that we really, I called on hospitals in Hawaii, in Pennsylvania, in the DC area, and all from Naples up to Tampa. And Sarasota Memorial is an exceptional hospital. And the team you have there and the work you do there is really on a university teaching hospital level. And actually you have become a teaching hospital. So we're very lucky here. And thank you so much, for the work
Thank
you
you for your kind words, and I agree completely that our hospital is world class,
do.
and
Mhm.
we have world class people here, all the way from the administrators to everyone at environmental services, and all the people that we don't think of as being key for our hospital. They are, and in this pandemic we have become very, very aware of that. And also thanks
Yeah.
for your support and all the work you do. You've been wonderful through this pandemic.
Yes.
Thank you
Well,
for the opportunity to talk to you.
I appreciate, we used to say when I was a hospital rep, if you've been in one hospital, you've been in one hospital. They're all different. And that's, we really do have a gem in Sarasota Memorial and all of you who work there. So I want to thank you all for listening, everyone. You've been listening to The Detail on WSLR 96.5, LPFM in Sarasota, Florida, and WBPV 100.1 LPFM in Bradenton, Florida. If drinking's no longer fun for you and separates you from other people, you can attend an AA meeting. They've been there. More information is available by phone at 941-951-6810 or online at aasrq.org. And of course, you can go to smh.com and look for their coronavirus information. They'll update you there on what's going on in our community. So thank you. Stay tuned for more public affairs programming here on your local community station. Make it a great day.